Shall we go? Dear PWNs, today we are going to discuss about some left out topics as a rapid fire revision for our FMGE. The first question is this one. What is our first question? One second. Let us go to some aspects of nephrology. Let me go to this topic. Today we are going to discuss about some left out topics as a rapid fire revision for our FMG. Done. Our first question is this. A 5-year-old boy referred to pediatric nephrology OPD from a secondary health center with anasarca. With anasarca, urine protein of 3+, serum albumin of 1.5 grams per deciliter, serum cholesterol of 400 milligram per deciliter. He was diagnosed to have nephrotic syndrome for the first time at 4 years of age and completed full course of steroids. Until now, he had 4 relapses and was treated with appropriate steroids. Now he is having 5th relapse. What is the next step of management? What is the next step of management? So what is this actually? What is the next step of management? Do I need to do renal biopsy? Second choice, start IV cyclophosphamide 500 milligram per meter squared once a month for 6 months along with the low dose tapering steroids. Start on AC inhibitors and statin. Start standard treatment prednisolone and assess the steroid threshold to maintain the remission. Can you tell me among this which choice is correct? Can you tell me what is the answer for this one? What is the answer? So let me go. Is it a nephrotic syndrome? When will you call it as a nephrotic syndrome? A basic revision. You will call a child with a nephrotic syndrome if urine albumin is more than 3 grams per deciliter per 24 hours, but it will be impossible to calculate 24-hour urine albumin. As a result of which we usually follow spot PCR. What we follow is spot PCR, spot protein creatinine ratio of more than 2 is defined as nephrotic range of proteinuria. Simultaneously, as a result of which your serum albumin will be less than 3 grams per deciliter and you will have anasarca, or else you will have edema, anasarca, or you will have edema. Apart from that, there will be secondary increase in cholesterol, because you lose albumin, the liver tries to produce albumin, but instead of producing albumin, it produces lipoprotein, leading to increased cholesterol, serum cholesterol of more than 250 milligram per deciliter. So this is the basic criteria you need to have for a nephrotic syndrome. This is the basic criteria to find out or to diagnose a case of nephrotic syndrome. 1. Second point, what is the treatment for nephrotic syndrome? So can anyone tell me what is the treatment for nephrotic syndrome? The treatment for nephrotic syndrome is, can anyone tell me what is the treatment for nephrotic syndrome? Let me see the chat box to look for the answer. What is the treatment? Can anyone tell me? So the treatment for nephrotic syndrome is steroids. So what is the steroids? Whether it is a first episode or subsequent episodes. So this is nephrotic syndrome. What is the treatment for first episode? First episode. What is the treatment? Let us see. So what is the treatment for first episode? The first episode treatment is 2 milligram per kilogram of prednisolone. Okay, 2 milligram per kilogram. One second, 2 milligram per kilogram. What happened? Right, 2 milligram per kilogram of prednisolone daily for about 6 weeks, followed by 1.5 milligram per kilogram on alternative days for 6 weeks. So this is the treatment for first episode. This is the treatment for first episode. So you will give 12 weeks of prednisolone. 6 weeks daily 2 mg per kg. Another 6 weeks 1.5 mg per kg on alternative days. So what is the treatment for subsequent relapses? What is the treatment for subsequent relapses? Subsequent relapses. The treatment for relapse is you give 2 mg per kg of prednisolone. So what you give? Here you give prednisolone is the drug of choice. So you give 2 mg per kg of prednisolone daily till remission is achieved. Till remission is achieved. What do you mean by remission? Remission means 3 morning urine albumin, 3 morning urine albumin, nil or trace. So you need to give prednisolone 2 mg per kg till remission is achieved. For example, if the child is getting remission, child is getting relapse by about April, let me say April, today is 24. So you need to look further, the child is having relapse. So how do you check relapse? Whenever any known case of nephrotic syndrome comes with edema, you need to check the spot PCR. You need to check the spot PCR. If spot PCR of 3 consequent days is 3 plus or 4 plus, that is total urine albumin. When it comes to spot PCR, if it is more than 2 days on 3 consecutive days, it is called as relapse. Now 24 the patient has come to you today. Now what I am going to do? So 24, 25, let me see, the patient has come to me on 24. So I am ordering for 25. So I am ordering 25, 26 and 20. What happened? Okay, 25, 26 and 27 spot PCR. I am ordering spot PCR. Okay, spot PCR I am ordering for 3 days. So my spot PCR becomes what happened? My spot PCR become 2 plus on 3 consecutive days. become 2 spot PCR more than 2 3 consecutive days. What happened? 1 second. Okay, on 3 consecutive days. So I need to start oral prednisolone. I need to start oral prednisolone 2 mg per kg for till the patient achieves remission. So what I am going to do, I will start steroids on 28, 29, 30 April 30, and I will continue for May 1, 2, 3 etc. May 1, what happened? So May 1, 2, 3 I am continuing. So what happens? When I give prednisolone, I will look for daily urine albumin nil or trace. Daily urine albumin I will do. 1 second. So daily urine albumin I will check. Then I will start prednisolone. 1 second. There is some disturbance with respect to choosing the ink because of sweat. Then I will start prednisolone. Then I will start prednisolone. What happened? The color is changing. 1 second. Let it dry for some time. Okay, so what will I do? I will start prednisolone for about 2 mg per kg from April 27, 28, 29, 30. I will do daily urine albumin. So by doing daily urine albumin or spot PCR, when it becomes nil or trace for 3 consecutive days. I repeat, when it become urine albumin become nil or trace for 3 consecutive days, or spot PCR becomes less than 0.2 on 3 consecutive days, then it means that the relapse is achieved. So till remission is achieved. So till remission is achieved, I will give urine albumin. I will give prednisolone 2 mg per kg daily. So let me say the child is going to get remission by about 3 to 7 days after starting prednisolone 2 mg per kg per day. So after achieving remission, I will give 1.5 mg per kg on alternative days. 1.5 mg per kg on alternative days for 4 weeks. Remember, in the first episode, I had given 6 weeks of daily steroids and 6 weeks of alternative day steroids. But subsequently, in relapses, I will give 2 mg per kg of oral prednisolone for till the remission is achieved, followed by 1.5 mg per kg of steroids on alternative days for 4 weeks only. So the treatment of subsequent relapses vary. Okay. The treatment of subsequent relapse. So what is the treatment? I will give 2 mg per kg per day till remission is achieved. Till remission is achieved, followed by 1.5 mg per kg per alternative days for 4 weeks and stop. What do you mean by frequent relapse? What do you mean by frequent relapse? Frequent relapse means, then comes, what do you mean by frequent relapse? Okay, then comes frequent relapse. What do you mean by frequent relapse? Frequent relapse means 2 or more episodes in 6 months, or 4 or more episodes in 1 year. So what is the treatment for frequent relapse? If you give prednisolone for a long duration of time, what will happen as a result of which the child will go for Cushingoid features. So what you need to do, you need to find out the threshold level of the prednisolone. Since in our case we had given, let me say, from April 28 to May 5, we are giving daily prednisolone. The child had achieved remission. Okay, the child had achieved remission, that is urine albumin nil or trace, from, let me say, May 3, 4, 5. So from May 6 to June 6, I will give alternate day prednisolone. 1.5 mg per kg on alternative days. But when you stop prednisolone, this child is relapsing. But when you stop prednisolone, this child is relapsing. So what you need to do? You need to slowly taper prednisolone. How to slowly taper prednisolone? Let me see. Now what I will do, from June 6 to July 6. From May to June 6, you had given 1.5 mg per kg of prednisolone on alternative days. From June to July 6, you need to give 1.5. Already you had given 1.5. Now you need to give June to July 1.25 mg per kg on alternative days. Then from July 6 to August 6, you need to give 1 mg per kg on alternative days. And from August to September 6, you need to give 0.75 mg per kg on alternative days. And it is followed by August to September 0.5 mg per kg on alternative days. You need to maintain this 0.5 mg per kg on alternative days from September, let me say 2023, and you need to give this 0.5 mg per kg for about 6 to 18 months. 6 to 18 months till September 2024. This 0.5 mg per kg on alternative days do not produce any steroidal Cushing effect. But if the child relapses at 0.75 mg per kg, it means what you need to do? Till then, you need to reduce the dose to 0.5 mg per kg on alternative days. But the child will require an additional 0.25 mg per kg that should be replaced either by cyclophosphamide oral. That should be replaced by oral cyclophosphamide or oral levamisole. Oral levamisole. So this is the treatment for steroid frequently relapsing nephrotic syndrome, or it is also the treatment for steroid dependent nephrotic syndrome. Also the treatment for steroid dependent nephrotic syndrome. What is steroid dependent nephrotic syndrome? If the patient relapses, that is two consecutive relapses within 2 weeks of stopping alternate day steroids or during alternative day steroids. So what does it mean? These subset of patients will be requiring either alternative day steroids or daily steroids. So some, when you switch from daily to alternative day steroids, they relapses, while some other will relapse when you stop your alternative day steroids. This is called steroid dependent nephrotic syndrome. Both in steroid dependent nephrotic syndrome and frequently relapsing nephrotic syndrome, the treatment is one and the same. What is the treatment? You slowly taper the alternative day prednisolone and bring it to 0.5 mg per kg on alternative days. And if the child can tolerate, or if the child doesn't show any relapse, you need to maintain that 0.5 mg per kg on alternative days for the next 6 to 18 months. If the child shows relapses at 0.5, maintain at 0.75 mg per kg. Not possible because the child will go for Cushing syndrome. So make it as 0.5 mg per kg on alternative days and add either levamisole or cyclophosphamide along with your alternative day prednisolone. By this way, you can achieve remission without any steroidal side effects. So let us go to our question per se. So what is our question? The child is 5-year-old. And first the child had relapse at 4 years. And within 5 years, the child had almost 5th relapse. So what does it mean? He is suffering from frequently relapsing nephrotic syndrome. He is not steroid dependent nephrotic syndrome. This is a case of frequently relapsing nephrotic syndrome. Renal biopsy is indicated in case of steroid resistant nephrotic syndrome. What is steroid resistant nephrotic syndrome? Absence of remission of. What is steroid resistant nephrotic syndrome? Absence of remission even after 6 weeks of daily prednisolone of 2 mg per kg is called as steroid resistant nephrotic syndrome. In those cases, you can go for renal biopsy. And what about IV cyclophosphamide? Again, IV cyclophosphamide is tried in cases of steroid resistant nephrotic syndrome and not in cases of steroid dependent nephrotic syndrome or frequently relapsing nephrotic syndrome, in which we use oral cyclophosphamide or levomethasone. You all know that all cases of nephrotic syndrome will have very high levels of cholesterol, as a result of which in steroid resistant nephrotic syndrome we will add statins, and because to reduce the proteinuria we will add ACE inhibitors. And again, all these first choices are meant for steroid resistant nephrotic syndrome. So what is the answer? The answer is start standard treatment with prednisolone and assess the response to treatment and assess the steroid threshold to maintain the remission. So this is all about treatment of nephrotic syndrome. So what we have discussed, what is called relapse, what is called nephrotic syndrome, a 2-minute revision. What is called nephrotic syndrome? Any child brought with anasarca or edema, you need to consider nephrotic syndrome, particularly if serum albumin is less than 3 grams per deciliter, urine albumin is 3 plus or 4 plus, or spot PCR for 3 consecutive days is more than 2. Along with that, a serum cholesterol of more than 250 mg per deciliter. The first episode treatment is 6 weeks of daily prednisolone followed by 6 weeks of alternative day prednisolone. 6 weeks of daily prednisolone is 2 mg per kg per day, whereas another 6 weeks 1.5 mg per kg on alternative days. What is called remission? 3 days of nil or trace early morning specimen. What is called relapse? 3 days of 3 plus or 4 plus for 3 consecutive day early morning specimen. That is called relapse. What is the treatment for relapses? The treatment for relapse is prednisolone 2 mg per kg per day till remission is achieved, followed by 1.5 mg per kg on alternative days for 4 weeks. Whereas what is called frequent relapse? 2 or more episodes in 6 months or 4 or more episodes in 1 year. In case of frequently relapsing nephrotic syndrome and as well as in case of steroid dependent nephrotic syndrome. So what is steroid dependent nephrotic syndrome? Steroid dependent nephrotic syndrome is characterized by presence of 2 consecutive relapses either during alternative day steroids or within 2 weeks of stopping alternative day steroid. This is called steroid dependent nephrotic syndrome. For both frequently relapsing nephrotic syndrome and steroid dependent nephrotic syndrome, the treatment is you need to slowly taper the alternative day prednisolone, and when it comes to 0.5 mg per kg, you need to maintain that for about 6 months to 18 months. In case of if the child requires more than this 0.5 mg per kg on alternative days, you need to maintain 0.5 mg per kg on alternative days. Along with that, you need to add either oral cyclophosphamide or levomethasone. This is the treatment for steroid dependent nephrotic syndrome or frequently relapsing nephrotic syndrome. So we have discussed in detail about nephrotic syndrome. Then let me finish about steroid resistant nephrotic syndrome also. Let me finish so that it will be useful for you. Definitely you will be getting one case from nephrotic syndrome. So what is called steroid resistant nephrotic syndrome? In steroid resistant nephrotic syndrome, your absence of remission even after there are guidelines which says that 4 weeks, 6 weeks, 8 weeks. As per present IAP guidelines, absence of remission even after 6 weeks of daily prednisolone of 2 mg per kg daily. Absence of remission. This is called steroid resistant nephrotic syndrome. So what is the treatment for steroid resistant nephrotic syndrome? Steroid doesn't work. So you need to go for what? Calcineurin inhibitors. You need to go for calcineurin inhibitor. What is that calcineurin inhibitor? You need to give cyclosporin. So you need to give cyclosporin for 3 to 6 months along with the statins, and along with the enalapril, AC inhibitors to reduce the proteinuria. So you need to give for 3 to 6 months. In case of remission, stop all. In case of no remission, what you need to do? Remission cannot be achieved means then you need to go for genetics. If genetic shows mutation positive, what are all the mutations that can lead to nephrotic syndrome? Podocin, laminin, actin are the mutation that can involve. If mutation is positive, stop immunosuppression and plan the child for renal replacement therapy or plan the child for renal replacement. Anyway, the child is not going to improve with your drugs. Whereas when the mutation is negative, along with cyclosporin, already the child is receiving cyclosporin now. Along with cyclosporin, either you can add mycophenolate mofetil, or you can add rituximab. This is the treatment for steroid resistant nephrotic syndrome. This is the latest guidelines with respect to steroid resistant nephrotic syndrome. Right. Second question. A 10-month-old child, let us go to the next question. A 10-month-old child weighing 3 kgs. How could a 10-month-old child will weigh 3 kgs? But here the child is weighing 3 kgs, has polyuria, polydipsia and delayed motor milestones. Investigation shows blood levels of creatinine 0.5. That means serum creatinine is normal, but there is hyponatremia, hypokalemia, hypochloremia and calcium little bit of low value, along with the bicarb of little bit high and the pH of little bit on the alkalotic range. Ultrasound shows medullary nephrocalcinosis. What is the diagnosis? Can anyone tell me what is the diagnosis? Let me see. What is the diagnosis? What is the diagnosis? Anyone who could answer? What is the diagnosis in this case? Can anyone tell me? So the answer is very, very simple. In case of renal tubular acidosis, you need to have acid. But here it is. Look at this. In acidosis, bicarbonate will be. In acidosis, your bicarb will be low, but here bicarbonate is high. So this is not a case of renal tubular acidosis. All acidosis will have a bicarb of less than, usually bicarb of less than 16 millimole per liter is low. But usually in case of renal tubular acidosis, it will be still lesser than that. We usually see around 4 or 5 in all those categories and varieties. Bicarb will be less than 16 millimole per liter. 1. Second, so this is not a case of renal tubular acidosis, because here the alkali is normal. Second, is it a case of diabetes insipidus? In diabetes insipidus, usually you will have what? You will have polyuria. Diabetes insipidus, usually you will have polyuria, and it will be characterized by increased serum osmolality. Increased serum osmolality means it will be more than 300 milliosmol per kilogram. If you find it is difficult, then a serum then you need to look for serum sodium. If the serum, so in diabetes insipidus, serum sodium will be more than 145 milli equivalent per liter. But here the serum sodium is low. Again, it doesn't fit into diabetes. It doesn't fit into diabetes insipidus because diabetes insipidus is characterized by high serum osmolality. And it is characterized by high serum sodium. Serum sodium will be more than 135 or will be more than 145. Normal is 135 to 145. It will be more than that. Here it is less. Again, let us come to hypoaldosteronism. What is the role of aldosterone? Aldosterone usually absorb sodium, absorb water. It absorbs, so it goes inside the body, and what will happen? So sodium will increase, water will increase as a result of the action of aldosterone, and your K plus will be secreted, H plus will be secreted. This is the action of aldosterone. But what happens in hypoaldosteronism? In hypoaldosteronism, what will happen? Okay, in hypoaldosteronism, what will happen? Your sodium will be lost in urine, water will be lost in urine. So what will happen? You will have low sodium and you will have low BP. Point number 1. Second point, potassium will be retained because the role of aldosterone to excrete potassium. Hydrogen will be retained. As a result of which you will get hyperkalemic metabolic acidosis. In case of hypoaldosterone. So when aldosterone is low, sodium will be low, water will be low, or else I can say BP will be low, potassium will be high, and hydrogen will be high. So pH will be low, acidotic range. pH will be less than 7.35. What is called pseudo-hypoaldosteronism? Pseudo-hypoaldosteronism is not due to aldosterone level will be normal, but aldosterone receptor is deficient. It is resistant. Aldosterone receptor is resistant. Okay, aldosterone receptor is resistant. What happened? Is resistant. As a result of which, sometime aldosterone will be high. That is called pseudo-hypoaldosteronism. The difference between hypoaldosteronism and pseudo-hypoaldosteronism is both are characterized by hyponatremia, hypotension, hyperkalemia, and metabolic acidosis. In hypoaldosteronism, aldosterone will be low, whereas in case of pseudo-hypoaldosteronism, aldosterone will be high or normal. Let us see whether this is a case of pseudo-hypoaldosteronism. For pseudo-hypoaldosteronism, potassium should be high. Here potassium is 3. It will be associated with hyponatremia. Yes, hyponatremia. But because of H plus retention, you will have metabolic acidosis. So bicarbonate should be low, but here bicarbonate is high. And again pH will be low, less than 7.5. Here pH is 7.46. So this is a case of metabolic hypoaldosteronism is a case of metabolic acidosis, hyperkalemic metabolic acidosis. But here you have metabolic alkalosis. Can it fit into Bartter syndrome? Let us see. What is the role of Bartter syndrome? So Bartter syndrome is the gene affecting the ascending limb of loop of Henle. So it affects the ascending limb of loop of Henle, thick ascending limb of loop of Henle. What is the role of it? Sodium will be absorbed, potassium will be absorbed, chloride will be absorbed. But whenever there is a mutation in that, sodium will not be absorbed, so sodium will be low. Potassium will not be absorbed, so potassium will be low. Chloride will not be absorbed, so chloride will be low. Because of that, you will have hypo. Along with that, because of one second. You have, because of osmosis, your water will also be excreted. Your water will also be excreted. Water will also be water will once again. Will also, what happened, will be excreted. It is automatically going to that mode. One second. So your water will also be excreted. So if water is also excreted, what will happen as a result of which? You will have hypotension. Water will also be excreted. Also be excreted. So as a result of which the child will have hypotension. The child will have hypotension. But what happens? Because of that, the renin angiotensin aldosterone system will be accelerated. The renin angiotensin aldosterone system will be activated. What is the role of renin angiotensin aldosterone effect? It will try to produce aldosterone. This aldosterone, in fact, try to compensate it. So because of this, water will also be lost. Water will also be lost, leading to renin angiotensin aldosterone increase. Renin angiotensin aldosterone will increase, leading to hyperaldosteronism. This aldosterone in turn cause H plus secretion and K plus secretion, leading to what? H plus secretion leading to metabolic alkalosis, whereas K plus secretion leading to hypokalemia. So all this pattern can be explained in this. Hyponatremia, sodium chloride, all are low because of the involvement of ascending limb of loop of Henle. Second point, because of secondary renin angiotensin aldosterone activity, your aldosterone causes H plus secretion, leading to metabolic alkalosis manifested as increased bicarbonate and still further decreases your sodium. So this is a case of Bartter syndrome. Second, All the following are features of nephrotic syndrome except edema, hypertension, hypolipidemia, hypoalbuminemia, massive proteinuria. So what is this? Let us see. What about nephrotic syndrome? What about nephrotic syndrome? Okay, what about nephrotic syndrome? Just now we saw urine albumin is low, as a result of which the child is having edema. Apart from that, your serum cholesterol will be low. After that, what will happen? Serum albumin will be low. Your serum immunoglobulins will be low. Because they will be lost along with your albumin. Immunoglobulin will be low, right? What else? Immunoglobulins will be low. What else? Your protein C, protein S, all will be low, as a result of which the child is prone for thrombosis. Will be prone for, as well as antithrombin 3 will be lost. As a result, child is prone for thrombosis because of wastage of immunoglobulin in the urine. The child is prone for spontaneous bacterial peritonitis. There is no hypertension in minimal change disease, and there is no hematuria. Hematuria and hypertension are features of nephritic syndrome rather than nephrotic syndrome. So let us see here. Edema can occur. The answer is yes, because of wastage of urine albumin. Hypertension is a manifestation of what? Hypertension is a manifestation of nephritic syndrome. Is it hypolipidemia? It is not hypolipidemia, it is hyperlipidemia. Is it hypoalbuminemia? Yes, the answer is hypoalbuminemia. Yes, massive proteinuria, the answer is yes. So, massive proteinuria can come, edema can come, hypoalbuminemia can come. So, what are all the things that doesn't come in idiopathic nephrotic syndrome? Neither your hypertension, it is hyperlipidemia rather than hypolipidemia. So the answer is both B and C here. Features of nephritic syndrome. Whereas, and also how to differentiate between a simple classification of differentiation of nephritic and nephrotic syndrome. It is very simple. Let me see. So nephritic and then nephrotic. Let us see. Nephritic usual age is 5 to 15 years. Why? Because it is usually post-streptococcal. Whereas nephrotic, it is the usual age is preschool group. Usually it is 1 to 5 years. It is prone to relapse to age beyond 5 also. Second, nephritic syndrome is characterized by hematuria, characterized by hypertension. This hypertension can manifest as CCF or can manifest as seizures. This is very important. A nephritic syndrome doesn't mean that should manifest with cola colored urine. It is usually it can lead to hypertension, and this hypertension can lead to CCF and seizures. Whereas hematuria unlikely to occur in nephrotic, hypertension unlikely to occur in nephrotic. Nephritic means post-streptococcal glomerulonephritis, whereas nephrotic means minimal change nephrotic syndrome. There are causes other than post-streptococcal glomerulonephritis, and there are causes other than minimal change nephrotic syndrome also. Cola colored urine. Okay, there is no genital edema. There is no genital edema. And remember, there is non-pitting pedal edema. There is non-pitting pedal edema. Pedal edema. Whereas nephrotic syndrome is characterized by pitting pedal edema. Characterized by characteristic feature of nephrotic syndrome is genital edema, and it is characterized by frothy urine and flat globules. And what are all the manifestations of nephrotic syndrome? Here hypertension will manifest as CCF and seizure, whereas nephrotic syndrome can manifest as spontaneous bacterial peritonitis, can manifest as thrombosis. So this is the basic difference between post-streptococcal glomerulonephritis and minimal change nephrotic syndrome. And again, post-streptococcal glomerulonephritis less likely to no relapse, whereas nephrotic syndrome is characterized by frequent relapses. Right. Now, what is this? In vesico-ureteric reflex, dilatation of ureter from which stage? And I had given you micturating cystourethrogram of a child which had recurrent UTI, and so we did a MCU, and the MCU revealed this. So what is this stage? Can anyone tell me what is this stage? What is the stage in MCU? So let me explain. Right. The most common cause for recurrent UTI. Is vesico-ureteric reflex. There are how to determine this micturating cystourethrogram. How to determine it? The investigation of choice is micturating cystourethrogram. It is divided as grade 1. Grade 1, there is reflex up to mid ureter. What is grade 2? Grade 2, here reflex up to pelvis. In both these conditions, no dilation of ureter. There is no dilation of ureter. Whereas grade 3, grade 4 and grade 5 are characterized by mild, moderate, severe ureteric dilatation. Mild, moderate, severe ureteric dilatation. So what is the treatment? Let me finish the treatment. So what will happen? Let me say, in grade 1 what will happen? So this is your kidney, this is your bladder. So what is grade 1? So this is your ureter. So there will be reflex of urine up to mid ureter. This is grade 1. So what is grade 2? Grade 2 is bladder, reflex up to pelvis. So what is grade 3, 4, 5? So this is kidney. What is grade 3, 4, 5? So mild dilatation, moderate dilatation, severe dilatation of ureter, severe dilatation of ureter, mild dilatation. So this is grade 1, grade 2, grade 3, grade 4, grade 5, grade 5. So what is the treatment? Let us complete the treatment here. The treatment for grade 1 and 2. The treatment for grade 1 and 2. The treatment for grade 1 and 2 is antibiotic prophylaxis. Is antibiotic prophylaxis till 5 years, till 1 year. I am sorry, till 1 year. If breakthrough UTI, unstop. If breakthrough UTI occurs, if breakthrough UTI occurs, then antibiotic prophylaxis can be prolonged. Prophylaxis can be prolonged. Okay. Whereas in grade 3, 4 and 5, antibiotics till 5 years. If breakthrough UTI occurs, then you need to go for ureteric reimplantation. Okay, definitely you will be having one question from this, ureteric reimplantation. So this is the treatment of vesico-ureteric reflux. So what is the question? The question here is, in which stage ureter starts to dilate? 1 no, 2 no, so it is 3. So the answer is 3. So but what is the identification of this grade in this film? It is, look at this, it is very tortuous, massively dilated ureter. So this is grade 5. The picture that is shown here is grade 5, whereas the answer is stage 3. Ureter when to start dilate? Stage 3 mild, stage 4 moderate and stage 3 severe. Then what is this? So 3 questions, nephritic, nephrotic as well as urology, one topic, vesico-ureteric reflux is over. Now what is this? A 1-year-old brought with pancytopenia, deafness and hepatosplenomegaly. Skeletal survey is shown here. The treatment of choice is stem cell transplant, filgrastim, calcitonin, biphosphonate. Answer, calcitonin, biphosphonate. Answer. So what is the spotter? Let me wait for your answer in the chat. What is the answer for this? Is there any clue here? I'll be waiting for your answer. Is there any clue here? Is there any clue? Okay. Remember, the bone is very dense. Usually in an X-ray, you will have cortex and medulla. Is it possible to see a medulla in this case? There is no medulla at all. Or else I can say bone within a bone. It is full of cortex. It is full of bone. There is no medulla at all. So what is this? Yes, very good. Yes, it is a case of osteopetrosis. So this is a case of osteopetrosis. This is a case of osteopetrosis. Petrosis, otherwise bone in bone appearance. This is called as what? Bone in bone appearance. Bone in bone appearance. As a result of which, what will happen? Bone in bone appearance. As a result of which, you will get the manifestation is pancytopenia. Pancytopenia leading to what? Pancytopenia leading to what? Extramedullary hematopoiesis. Extramedullary hematopoiesis. Medullary hematopoiesis. leading to hepatosplenomegaly. And you can have entrapment of cranial nerves, and also you can have entrapment of cranial nerves, It can lead to deafness or optic nerve compression, which can lead to deafness, which can lead to optic atrophy. Why it is so? Because it is a disorder of osteoclast. It is a disorder of osteoclast. From where your osteoclast arises? Osteoclast arises from macrophages. Rank-like ligand protein. This macrophages produced from bone marrow. So what is the treatment of choice? The treatment of choice is stem cell transplant. This is the classical X-ray, stem cell transplant. So look at this. This is the classical X-ray of bone within bone. This is the classical X-ray of bone within bone appearance. Classical X-ray of bone within bone appearance. Okay, bone within bone appearance. The treatment of choice is stem cell transplant. Choice is stem cell transplant. Okay. Filgrastim. There is no bone marrow. How filgrastim will work? It won't work. Calcitonin. Again, how it will work? It will not work. The role of calcitonin is to reduce calcium. Biphosphonate. All these are not the treatment of choice. The treatment of choice is what? The treatment of choice is what? The treatment of choice is stem cell transplant. So whenever you have a child with, I repeat, whenever you have a child with pancytopenia, hepatosplenomegaly, deafness or optic atrophy, kindly take an X-ray chest to look for bone within bone appearance. You need to see cortex and you need to see medulla. If you don't see medulla, and if this medulla is occupied itself by bone, think in terms of osteopetrosis, and the treatment of choice is stem cell transplant, because it is a disorder of osteoclast, and osteoclast is produced from macrophages. Macrophages are produced from bone marrow. This is a very, very good important spotter for you. And finally, what is this? What is this? Okay, what is this? A 8-month-old child presents with polyuria. Polyuria means it is a disease of, either it can be a diabetes mellitus or it can be a diabetes insipidus. If it is associated with urine, diabetes mellitus. If it is associated with sugar, polyuria. If it is associated with urine in sugar, you will think in terms of diabetes mellitus. But look at this child. This is a 8-month-old child. This is a 8-month-old child. Okay. This is a 8-month-old child. So less likely to be diabetes mellitus. And we don't know whether it is a case of diabetes insipidus. Other causes of polyuria are renal tubular disorders, like what are all the other renal tubular disorders, so let us have a good revision here. So I will give you a general approach to polyuria. Dear students, let me give you an approach to polyuria. So what is called polyuria? Polyuria means an urine output of more than 2 liter per meter squared per day, or it is more than 5 ml per kg per hour. 5 ml per kg per hour. Okay, either it is 2 liter per meter squared per day or 5 ml per kg per hour. This is called polyuria. Kindly rule out structural causes like spina bifida. You need to rule out UTI. You need to rule out structural problems involving the urinary tract. and then you need to do urine routine. You need to do urine routine. You need to look for sugar. Once I missed a case of diabetes mellitus in a 4-year-old girl by not doing urine sugar. So kindly do urine sugar. Type 1 diabetes mellitus is common in our pediatric population. And then you need to, one is urine sugar and another is you need to go for urine pus cells. Urine pus cells for UTI. Urine pus cells for UTI. Then you need to go for urine what? Osmolality. Urine osmolality. If urine osmolality is less than 300 milliosmol per kilogram, you need to suspect diabetes insipidus. If urine osmolality is less than 300 milliosmol per kilogram, you need to suspect diabetes insipidus. Then go for serum osmolality. Go for serum osmolality. If serum osmolality is more than 300 milliosmol per kilogram, then your diagnosis of diabetes insipidus is confirmed. Insipidus is confirmed. Very simple. Diabetes insipidus is confirmed. But your serum osmolality is doubtful, and it is not, and it is between less than 300, and it is less than 300 milliosmol per kilogram, then you need to do a water deprivation test. Water deprivation test. In water deprivation test, you are not supposed to drink any water for about 12 hours. So when you don't drink water, when you are not supposed to drink water, your urine output should not be there. Your urine output should not be there. But despite if you pass urine, it means you have diabetes insipidus. This is water deprivation test. Again, so how do you confirm diabetes insipidus? I repeat, serum osmolality more than 300 milliosmol per kilogram. I repeat, urine osmolality less than 300 milliosmol per kilogram. The diagnosis of diabetes insipidus is confirmed. Confirmed. Point number 1 is confirmed. 1. Second, if your urine osmolality is more than 700 milliosmol per kilogram, diabetes insipidus is ruled out. Diabetes insipidus is ruled out. Second point. Third point, if your third point is ruled out, if your urine osmolality is between 300 to 700. 300 means what? Less than 300 confirm, more than 700 ruled out. If it is between 300 to 700, do water deprivation test. Deprivation test under controlled condition. Deprivation test. If so, this is very, very important. 1, 2, 3 and then 4. 4 is if serum osmolality is less than 300, urine osmolality is less than 300. What does it indicate? That you are diluting both urine and blood. So what is the diagnosis? The diagnosis is psychogenic polydipsia. The diagnosis is psychogenic polydipsia. Or I can say compulsive water drinking. Compulsive water drinking. Or compulsive. Dear students, kindly you need to just look into these 4 points. You will have one MCQ. You can definitely crack one MCQ. And when diabetes insipidus is confirmed, you need to give arginine vasopressin. If after arginine vasopressin, serum osmolality normalizes as well as urine osmolality normalizes, means it is a case of neurogenic diabetes insipidus. In pediatric age group, the most common is Langerhans cytosis invasion of your posterior pituitary. If arginine vasopressin fails to normalize, then it is nephrogenic diabetes insipidus. It can be treated by giving indomethacin, thiazides, etc. So this is the approach to diabetes. This is the approach to diabetes insipidus as well as approach to polyuria. So instead of serum osmolality, you can also apply serum sodium. A serum sodium of more than 150 milliequivalent per liter in the presence of polyuria is diabetes insipidus unless otherwise proved. So what happens here? Here the serum sodium is high, the child is having polyuria. So this is here bicarb is normal, chloride is normal, potassium is normal, urea is normal. So considering all these facts, the diagnosis of diabetes insipidus is made. So the next investigation of choice is urine osmolality. It should be less than 300 milliosmol per kilogram to have confirm the diagnosis of diabetes insipidus. Then what is this question? Seventh question. What is this question? Seventh question. A 5-year-old child. Okay, a 5-year-old child presents with history of fever on and off for the past 2 weeks and petechial spots all over the body and increasing pallor for the past 1 month. Examination revealed splenomegaly below costal margin. The most likely diagnosis is. So what is this? Fever is there for the past 2 weeks. Petechiae is there and then pallor. So what does it mean? Pallor indicates. Okay. Pallor. So you have pallor. First point. Pallor indicates low hemoglobin. Then petechiae. Petechiae indicates low platelets. And then fever indicates low WBC. So what does it mean? You have pancytopenia. More than 1 cell involvement. Here 3 cell involvement. When you have more than 1 cell involvement, you need to think in terms of bone marrow infiltration. One is bone marrow infiltration. Second one is you need to think in terms of bone marrow infiltration. 2, you need to think in terms of autoimmunity. Autoimmune hemolytic anemia plus thrombocytopenia. Autoimmunity. Third one is hypersplenism. Most common bone marrow involvement infiltration is acute lymphatic leukemia. Autoimmune hemolytic anemia, the most common is SLE. Hypersplenism, you need to have a large spleen. In this case, you have pancytopenia. Splenomegaly is just 2 cm below the costal margin. Less likely to be a case of hypersplenism. Can it be an autoimmunity? Autoimmune disorder usually occurs in the peri-adolescent age group. So less, even though it is a possibility, considering the age, it is less likely. It is less likely. So hypersplenism is less likely because spleen is not that huge. Can it be an immune thrombocytopenic purpura? In immune thrombocytopenic purpura, the only involvement is platelet. But here, hemoglobin is reduced. WBC is, I presume WBC is reduced because the child is having fever. So less likely to be due to hypersplenism. What about aplastic anemia? Again, pancytopenia can occur in a aplastic anemia, and you all know that presence of organomegaly or splenomegaly rules out aplastic anemia and rules out ITP. So finally, zeroing all these facts, our diagnosis is acute lymphatic leukemia. Acute lymphatic leukemia. Remember, my dear friends, you need to suspect acute lymphatic leukemia. When to suspect? You need to suspect acute lymphatic leukemia when there is more than one cell involvement. And usually you have organomegaly plus bone pain. Why bone pain? Bone pain is mainly due to periosteal infiltration. Bone pain is mainly due to periosteal infiltration. That too, nocturnal bone pain. All causes of nocturnal bone pain, along with the constitutional symptoms, you need to rule out ALL. Then you have sternal tenderness or bony tenderness. Sternal tenderness or bony tenderness. In case of ALL, again it is due to periosteal infiltration. Your total count will be like this. It can be normal, it can be low, or it can be very high. But remember, your differential count. In differential count, what will happen in differential count? Your lymphocyte will be very, very high. Your neutrophil will be low. So predominantly your smear will have more of lymphocyte. For let me say, total count is 20,000. In that, lymphocyte will be more than 70%, and neutrophil will be 10 to 30%. Whenever you have a bicytopenia or pancytopenia in the presence of lymphocytosis, you need to think in terms of ALL in pediatric age group. Again, hemoglobin will be low, platelet will be low. Hemoglobin will be low and platelet will be low. Hemoglobin will be low and platelet will be low. This is the classical picture of an ALL. Again, people can ask you whether I can do a peripheral smear study. Definitely not. Peripheral study may miss blast cells. So you need to do a bone marrow to rule out acute lymphatic leukemia, and a presence of blast of more than 25% confirms your diagnosis. Presence of blast of more than 25% will confirm your diagnosis. More than 25% will confirm your diagnosis. So this is with respect to B cell ALL. This is with respect to B cell ALL. What is the manifestation of a T cell ALL? What is the manifestation of T cell ALL? T cell ALL usually presents in male, usually presents in adolescent age group, usually presents with mediastinal widening. And it will be associated with hemorrhagic pleural effusion, and pericardial effusion. This is the manifestation of a T cell ALL. T cell ALL. Okay, done. So what is my 8th question? What is my 8th question? Interpret the following results and give the diagnosis. Interpret the following results and give the diagnosis. Urine free cortisol 80 micrograms per meter squared per day. Serum cortisol is 18 micrograms per deciliter. Then the patient was subjected to high dose dexamethasone suppression test. Cortisol becomes low. Cortisol becomes low. That is less than 3 micrograms per deciliter. So what does it mean? The cortisol produced by something can be suppressed by giving dexamethasone. Can be suppressed by giving dexamethasone. Now how to approach a case of Cushing syndrome? Remember in Cushing syndrome, let me say how to diagnose Cushing syndrome in pediatric age group. In pediatric age group, Cushing syndrome. How to suspect Cushing syndrome in pediatric age group? The most common manifestation, not as you think that buffalo hum so many things. The most common manifestation is obesity and growth failure. One is obesity and growth failure. Pediatric Cushing disease. So from where this cortisol can be produced? One, it can be produced in pituitary. That is, pituitary can produce excess ACTH. One. Second, it can produced by extra pituitary ACTH. That is ectopic ACTH. 2. Third one is it can be produced by adrenal. More cortisol. Or finally it can be exogenous. What do you mean by exogenous? For example, in rheumatic fever you are giving 12 weeks of steroids. Your nephrotic syndrome you are giving 12 weeks of steroids. So exogenous. Remember, exogenous is the most common. And with respect to adrenal secretion of cortisol, it can be either adenoma. Adrenal adenoma, or it can be due to adrenal carcinoma. How to differentiate between this adrenal adenoma and carcinoma? Carcinoma is fastly progressive. And apart from cortisol, they secrete mineralocorticoids leading to elevated BP. Apart from that, they secrete sex steroids leading to hirsutism. Leading to adrenal androgens, they lead to hirsutism. So a rapidly progressive Cushing syndrome along with the hypertension and hirsutism is adrenal carcinoma unless otherwise proved. Now, how to approach a case of Cushing syndrome in children? Let us see. The first and foremost thing is you need to look for urine-free cortisol. If urine-free cortisol is low, it means that the body is producing less cortisol because there is an exogenous steroid administration. So the most common cause for Cushing syndrome in children is exogenous. I repeat, so many diseases we are giving steroids. In that, urine-free cortisol will be low. So if urine-free cortisol is low, the most common cause is exogenous or otherwise known as iatrogenic. Whereas if the urine cortisol is high, it means the body is producing. Then the next step is ACTH. If ACTH is high, it means if ACTH is high, it means either it can be pituitary ACTH or ectopic ACTH. Remember, then you need to go for high dose dexamethasone suppression test. If high dose dexamethasone suppresses your cortisol, then it is pituitary, otherwise known as Cushing's disease. Cushing's disease due to cortisol ACTH secreting pituitary adenoma. It usually occurs around puberty. But your ectopic ACTH cannot be suppressed by high dose dexamethasone suppression test. So you need to take a CT chest or CT abdomen. Because what are all the things that can produce ectopic ACTH? Your Wilms, your carcinoid, your neuroblastoma. All can produce ectopic ACTH, and here it will not be suppressed by high dose dexamethasone suppression test. If ACTH is low, then it is adrenal tumor. Either it can be adenoma or carcinoma. That's it. This is the approach to Cushing syndrome in children. Cushing syndrome in children. Okay. So what happens here? After high dose dexamethasone suppression, cortisol is reduced from 18 to 3. So what does it mean? 80 into 3. So high dose dexamethasone suppression test reduces cortisol. So the answer is pituitary. So what you need to do? Answer is pituitary. What you need to do? You need to take an MRI brain to look for pituitary tumor. My next question is, if MRI brain is normal, what will you do? If MRI brain shows pituitary tumor, then you need to go for surgery. If MRI brain is normal, then you need to go for, what is that? You need to go for what? You need to measure the ACTH level in the inferior petrous sinus. That is called inferior petrous sinus sampling. Inferior petrous sinus sampling of ACTH. This is the approach to Cushing syndrome. Done. Approach to Cushing syndrome. And finally, what is this? Neuroblastoma. So what are all the good prognosis and bad prognosis associated with the neuroblastoma? Remember, neuroblastoma, let me tell you some of the MCQs with respect to neuroblastoma. One second. It's chill. Okay. So what are all the manifestations of a neuroblastoma? Remember one manifestations of neuroblastomas. Remember, this is the most common most common abdominal malignancy. Most common starter, the tissue starter. One second. So this is the most common abdominal malignancy. Which one? Neuroblastoma. And the most common abdominal malignancy of infancy, and it is most common What is that? Extracranial solid tumor. Most common solid tumor is brain tumor. So this is the most common abdominal malignancy. This is the most common abdominal malignancy. One. Second point, abdominal malignancy. Second, and it is the most common extracranial tumor. It is the most common extracranial solid neoplasm. 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 Okay, most common extracranial solid neoplasm. What are all the manifestations of neuroblastoma? There are so many manifestations of neuroblastoma. Okay. So most common, thank you. So most common abdominal malignancy. Second one is most common extracranial solid tumor. Extracranial solid tumor. Most common solid tumor is your brain tumor. Third, so what are all the prognostic factors with respect to neuroblastoma? Many syndromes are associated with neuroblastoma. What are all the syndromes associated with neuroblastoma? One, opsoclonus myoclonus. Opsoclonus, this is the paraneoplastic manifestations of a neuroblastoma. A neuroblastoma usually presents with ataxia and then nystagmus. Second, a neuroblastoma can present with diarrhea. This is called Kerner-Morrison syndrome. A neuroblastoma can present with diarrhea. A neuroblastoma can present with limping because of the periosteal infiltration of the blast cells. This is called Hutchinson syndrome. Hutchinson, a neuroblastoma can present with, and a neuroblastoma involving the cervical region can present with Horner syndrome. And the neuroblastoma can be associated with Hirschsprung's disease. And this is, what is this called as? This is called neurocristopathy syndrome. And finally, you need to know something called stage 4S. I am not going to talk in detail about stage 1, 2, 3, 4 because all those things would have been covered either by the pediatric surgery faculty or by our pathology faculty. I am going to concentrate on stage 4S. You must be wondering, a tumor of stage 4 is prone to produce devastation because it spreads like anything. But as far as neuroblastoma is concerned, it doesn't produce that kind of devastation. The answer is this. Stage 4 is a small primary in adrenal gland, followed by small secondaries in liver, skin, as well as bone marrow. But remember, I repeat, but not bones. bones. But not bones. This is called stage 4 is prone for spontaneous regression. This is prone for spontaneous regression. This is prone for spontaneous regression. Okay, this is prone for spontaneous regression. This is all about neuroblastoma. And we all know that we are living in an era of prognostication. Whenever we do see certain factors, so when those factors are present, either we start a high dose chemotherapy, or else we will inform the parents that despite chemotherapy the child will not do well. So that is the importance of prognostication. So what are all the good prognostic factors? Hyperdiploidy is a good prognostic factors for any tumors. Tyrosine kinase A is a good prognostic factor. So there are so many good prognostic factors for neuroblastoma. All neuroblastomas are associated with 1p deletion. 1p deletion is a bad prognostic factor. NMIC, this is the most common prognostic factor associated with a bad prognosis. Oncogene, bad prognosis. Any translocation is a bad prognosis. So what are all the good prognosis for neuroblastoma? One is tyrosine kinase A is a good prognostic factor, and another is hyperdiploidy. One is tyrosine kinase A and another is hyperdiploidy. All others are bad prognostic factors. So the answer is D and G. Tyrosine kinase A is a good prognostic factor, and hyperdiploidy is a good prognostic factor, whereas all others are bad prognostic factors. Again, ALL just now we had explained. Which of the following cytogenetics has favorable prognosis in children? Which of the following cytogenetics has favorable prognosis in children? Let us see. Remember. Okay. Which of the following cytogenetics has got favorable prognosis in children? Okay, let us remember, always B cell has got good prognosis, T cell has got bad prognosis. That is the thing you need to remember. Almost any translocation in ALL is bad prognosis. I repeat, any translocations in ALL is bad prognosis except this 1221. All others are bad prognosis. And also along with that, you need to remember trisomy 4 and trisomy 10 has got good prognosis. Trisomy 4 and trisomy 10 has got good prognosis. Let us go one by one. ALL age group is between 1 to 10. So before 10, after 10 is bad prognosis. Females are prone to have B cell ALL, so good prognosis. Males are prone to have T cell ALL, so bad prognosis. Higher the count is good prognosis. Presence of organ infiltration is good prognosis. Presence of mediastinal involvement indicates T cell and a bad prognosis. Pre-B cell has got a good prognosis, whereas mature B and mature T cell has got bad prognosis. Hyperdiploidy, increased number of chromosome, has got good prognosis. As it was discussed now, trisomy 12, 21, 4, 10 has got good prognosis, whereas other translocations have got bad prognosis. Usually we start prednisolone immediately after the diagnosis. Whenever you have absence of blast cells at the 10th day of prednisolone indicates good prognosis, whereas presence of blast cells at the end of 10 days of prednisolone, even at the end of 7 days people does, indicates a bad prognosis. What is mean by minimal residual disease? MRD. What is this MRD? Minimal residual disease. This is here cytology will be normal. Cytology will be normal, whereas your abnormal cells, abnormal malignant cells are detected by means of PCR probes. Detected by means of PCR probes. And if the value is less than 0.01%, it is a good prognosis. and values of more than 0.01 percentage is a bad prognosis. It's a bad prognosis. This is all about. Definitely you will be having one question with respect to prognostic factors in acute lymphatic leukemia. Acute lymphatic leukemia. Right. So what is this? Boiled cabbage urine in which inborn errors of metabolism? Almost many acute inborn errors of metabolism are associated with abnormal urine order, and you need to suspect inborn errors of metabolism whenever any infant or newborn deteriorates without any cause, without any evidence of sepsis or aspiration. You need to consider inborn errors of metabolism as a diagnosis. Whenever any child is brought with unresponsiveness or death in the absence of microbiological positivity, you need to consider an inborn errors of metabolism. An acute inborn errors of metabolism usually presents with what is that? Usually presents with deterioration in the absence of sepsis. Think about inborn errors of metabolism. And the important clue for all inborn errors of metabolism, almost many inborn errors of metabolism, is abnormal urine order. Each and every inborn errors of metabolism has got specific abnormal urinary order. Based on that specific abnormal urinary order, you can get the diagnosis, what it is. So let us see. Sweaty fit urine order. Yes, as you said, sweaty fit urine order occurs in glutaric aciduria. Okay, maple syrup, swimming pool odor, where does you have? Hofskinuria. Swimming pool odor, Hofskinuria. Almost all inborn errors of metabolism are autosomal recessive, but very few are autosomal dominant. One such is Hofskinuria, and very few are X-linked recessive. Can you tell me what are all the X-linked recessive? X-linked inborn errors of metabolism? Yes, very good. Your Hunter, your Leishman, your ornithine transcarbamylase, your Fabry's, Hunter, Leishman, ornithine transcarbamylase, Fabry's are all associated with X-linked. Only males in the family will be affected. So this is another MCQ. What are all autosomal dominant? One is familial hypercholesterolemia, second one is Hofskinuria, third one is some porphyrias are autosomal dominant. Where will you get this maple syrup or burnt sugar smell? Yes, maple syrup urine disease, which is due to deficiency of what? Deficiency of alpha keto acid dehydrogenase. Where will you get this tomcat urine order? Tomcat urine order usually you will get in multiple carboxylase deficiency, which requires biotin. Sulfurous urine usually occurs in which condition? Sulfurous urine. Okay. In which condition you will get mousy or musty odor? Phenylketonuria. Where will you get boiled cabbage urine? Tyrosinemia. So where will you get this sulfurous urine? Sulfurous urine usually you will get in hypermethionemia. Okay, right. Though these are all the disorders, these are all the abnormal urine order with respect to inborn errors of metabolism. And you all know that the inborn errors of metabolism can be treated either with, so what is the answer for this question? Multiple carboxylase will have a tomcat's urine, tyrosinemia rotten cabbage urine, phenylketonuria will be having mousy odor or musty odor, isovaleric acidemia will be having a sweaty fit urine order. Inborn errors of metabolism are mainly due to deficiency of certain enzymes that takes place in the reaction. It can be treated by giving an enzyme replacement therapy. So what are all the treatment options for inborn errors of metabolism? One is enzyme replacement therapy. We don't have much enzymes, and enzymes are very, very costly. Second one is substrate reduction therapy. For example, let me say A plus B is converted to C with the help of enzyme E. When this enzyme is absent, what will happen? A plus B will be converted to an abnormal metabolite such as D. What will be the manifestations of an inborn errors of metabolism? Either due to reduction in the product such as C, or due to increase in the substrate such as A plus B, or it can be due to an abnormal toxic metabolite. The treatment can go like this. Either you can provide an enzyme replacement therapy, or these enzymes are supported usually by a cofactor. That is called cofactor supplementation. That is called as cofactor supplementation. Either you can give cofactors are usually vitamins, or else it can also be treated by reducing the toxic substrate or metabolite formed, and this is called substrate reduction therapy. We are in the following tabular column. We are going to discuss about the enzyme replacement therapy, cofactor replacement therapy, and substrate replacement therapy. Basically, we are going to concentrate on cofactor replacement and substrate reduction therapy. Where will you use B1? Thiamine. Thiamine is used in maple syrup urine disease. Thiamine is used in maple syrup urine disease. 2. Riboflavin is used in mitochondrial disorders. B6. Pyridoxine is used in homocystinuria. B12, methylmalonyl CoA is converted into succinyl CoA. So B12 is used in methylmalonic aciduria. And what is this? Sodium benzoate, sodium phenylacetate, arginine. All are used in urea cycle disorder as substrate reduction therapy. Your carnitine and metronidazole are used in acidurias, organic acidurias. Where will you use this nitisinone? Nitisinone is used one in alkaptonuria, and also it is used in tyrosinemia. Where will you use this miglustat? Miglustat is used as a substrate reduction therapy in Gaucher's disease. Tetrahydrobiopterin is used in phenylketonuria. And finally, the left out thing is betaine, B-E-T-A-I-N-E. Betaine is used in which condition? Betaine is used as a substrate reduction therapy in pyridoxine resistant homocystinuриas. By looking into this one single slide, definitely you can crack a question either from your NEET or from your INICET examination. So this flow chart is very, very important to crack at least one MCQ from your NEET or INICET. And finally, what is this? A 11-year-old boy is brought to the OPD with the following features: pubertal testicular volume with the development of secondary sexual character. While on OP he is having inappropriate laughter episode. What is the investigation of choice? It means the case is discussed regarding precocious puberty. So let me say an approach to precocious puberty. An approach to precocious puberty. What do you mean by precocious puberty? Appearance of secondary sexual character. Appearance of secondary sexual character, or else I can say this will confuse you. Instead, I am sorry. So what is precocious puberty? The first common sign of puberty is testicular enlargement. When you have a testicular enlargement, what is called pubertal testicular enlargement? Your pubertal testicular enlargement is more than dash ml. What is that? More than 4 ml. If you have more than 4 ml of testis, less than 10 years, it is called precocious puberty. What are all the causes for precocious puberty? The causes are like this. One is brain. Your pituitary can produce excess LH or FSH. Gonadotropins can be produced. Brain. Second, your LH and FSH like substances can be secreted by your ectopic tumors. Ectopic tumors or your HCG secreting tumors. What your Yuvraj Singh had is this ectopic secreting HCG tumors. It can be due to congenital adrenal hyperplasia. It was discussed in our sprint session in detail about congenital adrenal hyperplasia. Why precocious puberty occurs? It can occur in 21 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency, or it can be due to an adrenal tumor, secreting androgen, and or finally it can be due to increased mutation of testosterone receptors. So these are all the 5 causes for. So one more example. So let me say instead of 11 year, let me say 7 year. I am extremely sorry. Instead of 11 year, let me say 7 years, because by 11 years he has to get, it is 7 years. Let me say 7 years. Okay, right. So what are all the causes? Brain. Usually in pediatric age group, precocious puberty due to LH or FSH is always organic. It is not functional. In puberty with respect to girls, it is functional. Precocious puberty can occur as a manifestation of a familial tendency, but in boys it is always organic, and it is due to hypothalamic hamartoma, and this will manifest as inappropriate laughter episodes, and these laughter episodes are nothing but seizures. For that you will do surgery. Second, ectopic HCG can be produced by germ cell tumors. Congenital adrenal hyperplasia. So what is the investigation for first one? First one is MRI brain. Second one, usually it arises from the chest mediastinum, so that you need to go for a CT chest. Third, congenital adrenal hyperplasia. The investigation of choice is what? 17-hydroxyprogesterone. And finally, adrenal tumor, either ultrasound or CT abdomen. And finally, testotoxicosis. Here you will get pubertal testicular volume, and here you have bilateral testicular enlargement, and you can do a mutational analysis. So what is the investigation of choice? Here the child is having inappropriate laughter episode, and it must be due to an hypothalamic hamartoma. So MRI brain is the investigation of choice. MRI brain is the investigation of choice. And last but not least, let us finish with this milestones. Okay, right. When does a 3-year-old child can do all the following except 1. Unscrew lids and turn doorknobs. Can anyone tell me by what age it comes? It usually comes by 2.5 years. 1. Dress and undress fully. It usually comes by 3 years. Knows full name and gender by about 3 years. Tie shoelaces by about 5 years. Copies triangle by about 5 years. So a 3-year-old child can do A, B, C, but not D and E. And which of the following cannot be done by a 3-year-old child? It goes one and the same. Draws a triangle usually by about 5 years. By about 3 years, the child can do a vertical stroke, horizontal stroke, as well as it can draw a circle. Rectangle by about 4 years, triangle by about 5 years. Draw a circle, yes, it can do. Arrange 9 cubes. Remember, 2 cubes by about 15 months, 3 cubes by about 18 months, 6 cubes by about 24 months, and 9 cubes by about 3 years. So, a 3-year-old child can arrange 9 cube. Yes, the answer is correct. Can go up and down. So can go up and down by about 2 years, but it is same foot, both foot per step. But the child can do alternative step up by about 3 years, alternative step down by about 4 years. Goes up and down, I can agree. 2 foot per step, yes, it can does. Stand on 1 foot for 5 seconds. Yes, jumping can be done by about 3 years, hopping can be done by about 4 years, skipping can be done about 5 years. Whenever a child wants to jump, it has to stand momentarily on 1 foot for 5 seconds, so accepted. So what must be the answer? The 3-year-old child can does D, C, B, C, D, E, but not draw a triangle. Draw a triangle usually occurs by about 5 years. So with this, we are finishing our topic for today. So let us meet one more discussion on Thursday for exclusive INICET. With this, I am stopping my class for today. Bye bye. See